IVUS is nowadays an integral part of our cath lab. So the knowledge of IVUS is very much essential. The discussant of this session is Dr. Takashi Akasa, Dr. Tanhui Chim, Dr. Afzalur Rahman, Dr. Aftab Khan, Dr. Ashok Datto, Dr. Arun Maske, Dr. Rupali Khanna, and Dr. Dhiman Boning. May I request our first presenter, Dr. Arun Mohanty. He will present on IVUS procedure step by step, lesion morphology and interpretation with IVUS.
So, good afternoon, everyone, and thanks the Bangladesh Live organizers for this opportunity, particularly Dr. Mohsin Ahmad. It's my pleasure to be here in Dhaka for the first time, and it's a lovely city. Let us discuss very basics about IVUS. It's as told, it's very integral. We do a two-dimensional angiogram, which is a 2D shadow, and shadows are always deceptive. It can be really deceptive, and it's not the reality. So, if you see this angiogram, you can see it's somebody will say it's 50%, somebody will say 30%, somebody will say 70%. This view, that view. So once you are doing two-dimensional imaging, always there is a confusion. Go inside the vessel and look what is that and what are other information. You can get a lot of information from the IVUS. So IVUS is not a big problem actually. You can learn very well. All of us are doing echo. If you see a myocardium like this is the pericardium. Adventitia is the same, nothing but the pericardium of the artery. And if you have the myocardium which looks dark, media looks the same. And this is ultrasound principle. And if you see the metallic walls, you can see the stent studs so beautifully like this. These are metals. And if you have calcium like MAC here, mitral valve annular calcium, calcium looks like this in echo. It will not look any different in all IVUS. It looks the same. So the principle remains the same. And IVUS based on the ultrasonic wave, it takes 360-degree tomographic sections of the vessel, and we usually get two views. One is cross-sectional view, just to analyze the vessel morphologies and other thing. For length assessment, for the diameter we take cross-sectional majority of time. For length assessment, we usually and branch pattern study, we take a longitudinal view. And a normal vessel looks like this. If you have 3-layer pattern, you can have a adventitia which looks really bright, most brightest thing. There is a thin layer of media which is a black band around, and the innermost layer is intima. External elastic lamina and internal elastic lamina is the bordering media, but we can't see so clearly in IVUS in many of the patients. We don't see. Now coming to the basic morphology interpretation, this is a normal vessel as I discussed. A diseased vessel looks like this. You have the media intact, but there is something intraluminal growth, whether it's a plaque or a thrombus or whatever. These are all diseased vessels. A normal vessel looks like this. Now coming to the concentric plaque, if you have this kind of plaque, there is some ingrowth inside the lumen which is looking all throughout, and it's a concentric location. So this we call as a concentric plaquing. And eccentric are like this. There is one side is free, the other side is totally diseased, almost occluding the. So it can be concentric, it can be eccentric. Now coming to the lipidic plaque, you can get lipid contents which looks really dark. Lipid looks dark both in IVUS and OCT, and the ultrasound beam gets attenuated here. That's why these are called in an attenuated plaque if they are present more than 60 degree of the circumference, lipid arc, and the length is more than 5 millimeter. That has been correlated with the histopathology, and these vessels usually they have foam cells, macrophages and other things, and they have a necrotic core, thin cap usually, and they are the vulnerable plaque, and there is a lot of muck inside, and it has been correlated with histopathology. What is the clinical significance of this plaque? We see such things in OCT also. So attenuated plaque, this is a 43-year female non-STMI, very tight proximal LED lesion. Look at this lesion. Anybody will be tempted to put a stent from left vein to LED. Very easy, no calcium. So we did an IVUS. You see, if you don't see anything beyond the catheter like this, without any calcium or a metallic stent, that means this is a lipid pool with necrotic core. So you see, it's all looking dark. There is no reason it should be looking dark. The ultrasound beam is getting attenuated here totally. That's why it is called as attenuated plaque. And these attenuated plaque, they have very high chances of no reflow, because once you do a balloon dilatation, this total muck is going downstream to cause a no reflow. So this is what one has to identify morphologically. We are doing a balloon dilatation. We knew this patient can land into a problem of no reflow. After balloon dilatation, some no reflow, slow flow, SNP was given, flow improved. We put a 48 stent, 3.5 Lettman to LED, doing careful dilatation of Lettman stent, and immediately there was a no reflow. Patient collapsed and had a cardiac arrest, had to be intubated, and IBP was put in. But we are clear in our mind what we are dealing with because of our imaging finding. We knew there is a large material of necrotic core, which is the problem. We need not to dilate further. We need not to worry. We need not to put another stent thinking dissection. Nothing doing. Just support patient's hemodynamic. Keep you calm. Intubate the patient. This was the scene in the cath lab, and after 2 hours, the patient was extubated and discharged normally. So once you know what you are dealing with, you can tackle very well. Now coming to fibrotic lesions. Fibrotic lesions are the lesion morphology where the tissue texture or the echogenicity of the tissue becomes identical to the adventitia. It's not that bright like a calcium. It is allowing your ultrasound to penetrate. You can see the surrounding tissue. It's similar. So that is a fibrotic tissue. And fibrotic tissue you have to identify, because stent under expansion can be a problem. You have to modify not by a rota or a IVL, but at least you can use a high pressure NC balloon in such cases, or a cutting balloon, to modify the lesion before opening your stent. So fibrotic lesions are sometimes troublesome, so you have to prepare accordingly. And this is calcium. Calcium will not allow any ultrasound beam to go beyond. So you see like attenuated plaque darkness, but there is a calcium. This is not attenuated plaque. Because of the calcium, it is not coming out. So this is what is calcium. And we have different calcium scoring system. I'll not go into detail. We have nodular calcium. We have different types of nodule. In IVUS, you can go and see. And there are calcium scoring. Based on the scoring system, you must identify calcium score more than 2 in an IVUS calculation, so that you use appropriate tools like IVL or ROTA or orbital to modify your calcium before doing angioplasty. Dr. Akasaka can come to the chair. So now coming to the complex images. So calcium is a problem. One has to identify calcium. Now complex images, these are complex basic images. We must identify a dissection in IVUS. If you see this kind of flap inside, floating inside, after a balloon injury or a spontaneously in a spontaneous coronary artery dissection, you can very well know this is a dissection, and major dissections should be treated. The major dissection by definition is more than one quadrant of dissection extending into the media, TME3 compromise, flow compromise, or there is a large hematoma involving a dissection, are to be tackled and to be treated. Without recognizing this, your post-stent result may be disaster, and the patient can land into acute stent thrombosis or a chronic stent failure. Now thrombus are nothing but these are presumptive in IVUS. OCT is a better tool for identifying thrombus, with a red thrombus, white thrombus, but you can appreciate thrombus. This kind of filling defect in the coronary, where the other side of the vessel you can see the flow, there is some filling defect here. This kind of variegated consistency, depending upon the duration of the and the content, whether it's a platelet rich clot or a fibrin rich clot, you can get this kind of variegated consistency of the filling defect. These are the thrombus, and thrombus must be identified. If you are not recognizing thrombus, not preparing your vessel with vasodilator or other thing, you may land into trouble. And plaque erosion can be identified by IVUS by this thrombus. If there is no major disease or plaque rupture, one can keep these patients on medical follow-up and bring them back for imaging or an angiogram, and stent can be avoided. And this is hematoma, this helmet shape, which is separating the intima from the media, and its subintimal collection. So this is a helmet shape thing, is a hematoma. A large hematoma has been correlated with stent failure. If it is a stentage hematoma, it should be treated. Now coming to the stent assessment, under expansion, malapposition, mind it, under expansion of the stent is the single most predictor for stent failure. So it should be identified. No amount of stent under expansion should be left like this. The patient is bound to come back. So this is a under expanded stent. Look at this vessel size and look at the stent size. You can see such small stent. This is undersized and under expanded stent. The stent can further expand. If you calculate the expansion limit of the stent, it will be at least less than 70%. So the optimal stent expansion should be more than 80%. Ideally should be 90% to the distal and proximal diameter of the vessel matched. Now coming to the malapposition. Malapposition is a fully expanded stent cannot, if it is not touching the wall of the vessel or lumen of the vessel, there is a gap between the vessel wall and the stent. In a fully expanded stent, it is called as a malapposition. That means a hanging stent inside the lumen. It's not sized up to the vessel. And if we are putting a 3O stent in a 4O vessel, despite of adequate dilatation, you may not reach a 4 millimeter. So you may land into a malapposition, particularly in a large vessel like left main or a bigger proximal vessel. So the small segment of malapposition is not associated with any events, but in a second procedure, if your wire is likely to go abdominally, and if you don't recognize that, you can deform the stent totally and you land into problem. That's where the problem starts. So smaller malappositions are not associated with stent thrombosis or stent failure, but this should be in a left main particularly, it should be appropriately apposed for the second procedure so that the second operator can easily enter into, otherwise he can deform the stent inadvertently. This is a under expanded malapposed. You can see under expansion, malapposed struts and undersized stent for the vessel. Look at the stent size and the vessel size. That's where the role of imaging comes. You are angiographically getting a very good luminogram of 2.5 millimeter vessel, but this vessel is more than 3.5 millimeter. If such under expanded stent is left, then these vessels are prone for second procedure. Now the second important edge problem post stenting is geographic miss. This geographic miss, by definition, if you leave a area of disease at the stentage which is more than 50% of the plaque burden, then this is called a geographic miss. You can see this stent has ended in an area where the plaque burden is more than 50%. That has been shown in studies. If you leave 50% disease atheroma at the stent edge, whether it's a proximal or distal edge, your stent failure rate is high. So this is a geographic miss. Now stent edge dissection I discussed. You can see a beautiful stent edge dissection and acute stent thrombosis in a malapposed undersized stent. You can see thrombus filled, and look at the vessel size and the stent. This is acutely thrombosed stent in an under expanded undersized stent, and this is malapposed undersized stent, and this is a stent in a false lumen. You can see this is the true lumen with all three walls. The IVUS catheter is in the true lumen. You can see there is a stenting of the false lumen. Usually, if you don't recognize this thing in a CTO, that's why the pre-imaging is much more important, and post-imaging it's very difficult to correct such complications. So if you are doing a pre-imaging, you realize you are in a false lumen, you need not to be stented before you achieve a true lumen access. Now the sizing of the vessel, remodeled arteries are important. Remodeling, one has to recognize if your distal vessel and proximal vessels are smaller and it has grown, this is a natural adaptive phenomena. Once there is atheroma, it tries to adapt the atheroma and grows in size, and these vessels, positively remodeled arteries, are by and large unstable arteries because they have lot of lipidic core and other things, then that can cause stent SCS, and if you are not careful, can cause other problems. Negatively remodeled arteries are smaller arteries than the distal and proximal difference, and like this, and you can see the vessel size here, and the distal vessel is bigger. This is a naturally remodeled, negatively remodeled. Particularly in CTO or chronically underfilled artery, you get such vessels, and if you are not careful and if you are aggressive here, not realizing negative remodeling, you can lend into a perforation or rupture. Now coming to surrounding structures, like this is a pericardium, which is a bright echogenic structure with a fluid here. Every cardiac cycle you can see this goes parallel, and if you are fortunate you can see some vessels here which is diagonal, and opposite to that are septal in a LED. The importance here is, if you have a calcium sitting on the other wall of the vessel and this is a pericardium, look the thickness of this wall here, it's totally superficial, and if you are not careful on the size and you are very aggressive and a calcium nodule or something sitting here, that is the area where you lent into a perforation and a rupture into the pericardium. Now there are some other, this is a pericardium, the confusing structures are, this is a septal artery away from the pericardium, and you will get diagonal somewhere here, and this is a cardiac vein. Cardiac vein never joins to the vessel. If you follow the septal, they will come and join, or a diagonal will come and join, but these cardiac veins will go parallel and disappear. So this is a cardiac vein and this is a mitral bridge. Mitral bridge is a I sign. So these are the structure we usually confuse, pericardium, cardiac vein, and you can see the muscle bridge, the I sign. There are two muscle looks dark, as I told. There are two muscle bends. So probably my time is off. Can I take 5 more minutes? Yeah. So, and the landmarks, venous landmarks are important. I'll not go into detail, and one can see. I'll go to the other interesting thing, artifacts. The IVUS artifacts are important. One has to identify what are the artifacts we deal with IVUS. This is a typical of your external electrical interference in the system. So you have to check your cath lab to get these things out. Otherwise, you don't interpret your images. This is the electrical interference of the vessel. Now, the most important artifact is air bubble artifact. You can see, if you don't purse your catheter properly, you can't see proper structures around, and the air bubble can mask the finding. And depending on the location of the air bubble and the amount of the air bubble, they can produce various kind of artifacts. This is another variant of air bubble artifact. You don't see anything. So your catheter should be properly pursed before doing anything. This is another few bubbles. They are doing a reverberation artifact, air bubbles transmitting the ultrasound waves like this. So these are air bubble artifact. A ring down artifact we don't see too much nowadays with a rotating catheter. It was most with a fixed array catheter, where if you don't nullify the ring down, you don't estimate the luminal thing, this area you can't do any estimation like this. Nowadays rotational catheter don't have this. This is a stagnant flow artifact. The vessel has a tight disease, or your catheter, IVUS catheter is choking this vessel. So you get, with a high definition catheter, you can see spectral appearance like a spontaneous echo contrast in the LA. This is a stagnant artifact, and this is a flush artifact. If somebody injects into the vessel, you can see this kind of, this is a flushing artifact. Somebody has injected some saline or something. And sluggish, no reflow, you can see such kind of stagnant artifact in a vessel. With acute MI, in a distal vessel, when the flow is not very good, you can see such thing. Guide catheter artifact. This is guide catheter artifact. You can see surrounding reverberation with fixed orifice, and this is a guide catheter artifacts. Side lobe artifacts are seen when there is a tangential reflection of the ultrasound beam. It can give a false appearance like this, the linear shadow here. This is a side lobe artifact, may mimic as a edge dissection many a time. Can you see this? This is a edge dissection. It's not edge dissection, it's a side lobe artifact. And reverberation artifacts, if you do a calcium modification, sometimes the ultrasound beam reflects like a mirror to and fro, and you can get this kind of reverberation artifacts. Many time in a they've suggested, if you get a post rota or something, a reverberation artifact, it usually suggests you have polished the reverberation artifact calcium, and you are more able to break this calcium. And in stent also, this reverberation artifact, you can see, these are ghost stent images. The stent ultrasound is getting reflected, so that's why you are getting ghost stent artifact. These are not a stent over a stent or a two layer of stent. Never mistake that thing is a stent. These are ghost stent artifact because of the reverberation effect. This is catheter motion artifact. Your vessel can move here and there to and fro, and the measurements are never accurate in such ways. Patients, if you are taking measurements in these views, then your measurements can be difficult, and you can get a discontinuity of the vessel wall due to the to and fro motion. And NERD, all of us, we know if there is a IVUS or something is getting very tightly trapped, the catheter cannot rotate completely, then there will be no uniform rotation of the IVUS catheter, because a rotating catheter, because of some mechanical problem, that can give a smearing kind of effect in the IVUS image, and you cannot interpret anything. This is very common, so you have to adjust your IVUS or make the catheter is not very much tightly fixed or something like that, so that you can take a proper picture. NERD images, if you don't disengage the catheter, the measurements can be totally different, because these areas are not, these are NERD, these are not actual images. If you disengage your guide and take a proper picture, the images are different. You can compare this thing. And there is a fold artifact sometime, particularly in a concertina, what we say, you can see this kind of folding artifact. These are nothing but the artery is kinked over in a tortuous segment because of the wire, and these are not disease segment. So, so to conclude, IVUS is an extremely useful tool to eliminate angiographic ambiguity, your doubts. You can go inside, assess lesion morphology. Very useful in planning for a PCI in a complex lesion, particularly in calcium. What are the tools to be used? What is the calcium score? How to modify the calcium, and what size stent to be taken? And after deploying the stent, the under expansion is a single most predictor. One has to be very careful. Simultaneously has to look for geographic miss and other major dissection or hematoma, and it improves not only the acute result but also the long-term outcome. Thank you very much for it.